And I see that our next person has joined. I'm just going to move some of the stuff off my screen so I can just see a little bit better. And I would like to thank Valerie. I apologize that I know some of our attendees had a lot of difficulty with the audio, but I hope that we kind of sort of conveyed the message. And I encourage you, like, if you're interested, it is paid for by Kidney Cancer Canada. It is available on our website. You just go across the banner and you can click and join. It is a pilot project, so it is going through medical assessment. So there may be a survey or two that you have to fill out in order to, collect information so that they can put it to the research. But it's a lot of fun. It's different. I will say it's different, but they offer cooking and nutrition, which is excellent. They offer graduated exercise. So if someone's not, capable of doing a lot of heavy exercise, they do easy, medium, and a little bit more difficult. As I said, if you need a buddy, you don't have someone to talk to about your kidney cancer, because not everybody wants to talk about it with family members and friends. They will match you with a patient buddy, and you can do a call once a week. And if you find you get into it and it's not for you, you can withdraw. There's always that freedom of choice. But if you think you might be interested, I encourage you to join and find out what it's about. And I think you'll find it's a lot of fun. So I would now like to move along in our agenda and welcome Caden Jobin. I think he's coming.
Yeah, sorry.
Caden. Oh, Caden, you're outside. It looks beautiful.
Yeah, I wish this is what it looks like here. Sadly, it is not.
I hear you. It's snowing profusely here. So it's looking very Christmassy, which is nice. I need a little motivation to get that Christmas shopping for grandchildren, but you're not there yet.
No, but should probably get started anyway.
I'm just going to do a quick introduction, if you don't mind, Caden.
For sure.
So people know who you are, and I'll add just a little bit myself. Caden is a medical student at the Cummings School of Medicine in Calgary, who previously did a master's degree in neurosciences. His interest is in helping to develop resource stems from his experience when his wife underwent a nephrectomy for renal cell carcinoma in 2022. And he noted a lack of available resources about the processes for patients. So Caden took it upon himself, and he developed a resource to educate renal masses, evaluating an educational resource for nephrectomy procedures. And we have put together an excellent booklet. I am so excited about releasing this. It's just ready to go to print. And I'm going to let you talk about it, and maybe a little bit about the research side about it too, if that's okay. Because you're also doing a little bit, is it a research project or a pilot project, or an actual research project? So I'll let you talk a little bit about that, and I'll let you take it away. Thank you, Caden.
Well, thank you so much for the introduction, Christine, and hello, everyone. Thanks for being here today and coming for all of these awesome presentations. So yeah, basically we put together an educational resource for nephrectomy procedures, which is kind of the primary surgical intervention for kidney cancer. So mainly focused on trying to help educate surrounding that. And I did that with Dr. Gatto, who's one of the urologists here at the Southern Alberta Institute of Urology. So you'll see his name throughout. So first, I'd like to just start with kind of some background information on kidney cancer as a whole. So kidney cancer is 10th most diagnosed malignancy in Canada, with about 8,100 cases per year. So this represents a pretty significant burden on people in Canada. The incidence has been increasing in recent decades, and this is thought to be somewhat multifactorial. So one of the reasons is that Now, almost everyone who goes into the emergency room is getting imaging of some kind, whether it's an ultrasound or a CT scan, and that's leading to more cases being picked up. But there's also some underlying reasons that we aren't quite too sure about because the incidence in young people less than 50 is rapidly rising, and there are theories, but no real solid answers as to why this is happening. Now, if caught early on in stage 1 or 2 disease, the survival rate is quite good at 5 years, at about 85%. And most of the time in these stages, it's managed surgically, which essentially removes the cancer through surgery. And sometimes there's a need for some additional therapies afterwards. But generally, patients have really good outcomes when it's caught early and managed surgically. Unfortunately, if we let things progress, this raises our mortality rate quite significantly. So the 5 year mortality rate across all stages of disease is around 35%. And so that's taking in those stage 1 and 2 cases as well. So if you have 15% in the stage 1 and 2 cases, then there's a much higher rate in those stage 3 and 4 cases to get an average of 35%. In terms of the current standards of care, there are a lot of approaches to managing kidney masses and largely depends on stage and size. And I'm sure you'll hear from others throughout these talks today that will kind of help clarify this a little bit further. But I wanted to go through just some of the therapies. So for smaller masses, less than 4 centimeters, a lot of physicians will consider just using surveillance or ablative therapy. And so that's when they go in with a needle and apply either some freezing or some heat to essentially kill the tumor cells. With these smaller masses, there's about a 40% chance that they're going to be benign. And so there's definitely a much less urgency surrounding treating these surgically. Although if surgery is tolerable, for example, a patient is doesn't have any conditions that would make anesthesia risky, then surgery is also often presented as an option for patients with these types of masses. If your mass is greater than 4 centimeters, usually the definitive therapy is surgery. So that this can be done with a partial nephrectomy where a part of the healthy tissue of the kidney along with the mass is removed in order to create that clear margin. And then it can also be done with a radical nephrectomy where the entire kidney is removed. And the reasoning for doing either partial or total is really dependent on the surgeon's preference and where the mass is. But in general, it's better to have a partial nephrectomy, and that's because we want to preserve kidney function. If you lose kidney function, it really impacts your body's ability to filter out toxins as well as to handle water. And it can make your heart upset or it can make your heart it can make it harder for your heart to pump if you're not able to handle the water that your body is producing as well. So definitely a better option to go with partial nephrectomy, but it's not always possible. Now, when we get into metastatic disease, surgery is often not considered because even if the kidney and the associated mass are removed, the other masses that are present in other areas will tend to grow and spread. And so generally in these cases, then we've kind of progressed to systemic therapies. So you can see some of them on the slides. Immunotherapy, for example, is commonly used. And then these targeted therapies that are targeted to specific molecules on the cell receptors. Radiation and chemo have less of a role in kidney cancer, and I think that can be one of the kind of distinguishing features, or one of the tough parts, is that people often assume that maybe if you're undergoing kidney cancer treatment, that you might be getting chemo or radiation, but those aren't quite as common. So just kind of a note on that there. But overall, the primary curative therapy is nephrectomy, and so it's really important that patients understand, especially when coming in with the earlier stage disease, that what a nephrectomy actually means, and making sure that they're kind of aware of the risks and benefits of that procedure, and then also making sure that patients are aware of their options, because as we outlined here, there are also other options that can be considered beyond just nephrectomy. Um, Unfortunately, there are a lot of challenges with communicating the details of procedures, especially in a real world setting. In a real world setting, physicians may have a resident that's seeing a patient, or they may have medical students seeing patients, or they may forget to explain parts of the procedure that seem intuitive to them, but are not necessarily intuitive to patients. And as there are quite a few previous studies that unfortunately demonstrate that, especially in surgical care, patient understanding of these procedures is quite poor. And even when there's a kind of a standardized informed consent discussion that's being used, where the risks and benefits are kind of meant to be explained, patients understand on average 30% of the risks and benefits. And there's a couple studies here that have kind of shown that. And this unfortunately increases worry regarding procedures and decreases satisfaction with the results of surgery. And so, actually, one of these studies is a larger study in the US that demonstrated in settings where patients have a low satisfaction, there was actually an increased rate of post-operative complications by around 11%. So, it's not just that, we're worried about, patients not being satisfied with the results of their surgery, but it's actually translating into tangible outcomes too, and into worse outcomes following surgery. So really important that this level of communication is set, and that patients are kind of into that decision making process there. Um, and it's been shown that if we can provide additional education resources surrounding procedure, it decreases worry and also improves satisfaction post-operatively. So it's not that there hasn't been evidence showing that if we add in educational resources, it makes things better. This is the case. Additionally, to add to understanding, I think recall is a huge challenge. I think we all struggle to remember every detail of things that are communicated to us verbally, and much less when we're experiencing the stress and worry of a potential new cancer diagnosis. And so previous studies in other areas of surgical care have shown that the estimated recall from consent discussions is around 25%. So quite poor. And this is, again, even when standardized information is presented to every patient. And so I think it's also important to note that patient satisfaction is going to be linked to recall, because if a patient doesn't recall a risk or a benefit, and then they have that, potential side effect of a procedure, I wouldn't be very happy if, I was having a side effect that I didn't know could happen. And I think that most patients wouldn't be. And so, it's not important that patients understand every detail of a surgical procedure, but it is really important that they at least understand why the procedure is being done and what the potential risks or drawbacks. And can also be really nice if they remember follow-up plans. I can't count the number of times, or I've heard people say, yeah, I had, this done, but I don't really know what's next or what's going to happen afterwards. And so really important to integrate that too. And there have been a few potential solutions in existing research. And so things that exist include things like digital interactive programming. So this would be like you go and you log into and you do modules or videos. There's also paper digital conversation guides, paper digital educational guides, and then conversation guides, which are actually an intervention for physicians. So kind of to help guide their conversations and make sure that they're presenting a standard set of information to every patient. Of these options, the most feasible usually is these paper educational resources, because these don't require patients to be tech savvy and access these kind of complicated online modules. And then they also don't turn, the conversation that your physician's having with you into kind of a standard set of a standard conversation. Because ultimately, I think very few people want that. They want to have a personalized conversation and not one that's kind of set in stone from the outset. So that's kind of shaping the direction that we chose to go for this educational resource. Was we thought that paper digital educational guide sounded the best of these options. And so, KCC already has some amazing educational resources surrounding nephrectomy, and definitely fill in the gaps regarding education. And you can see some of them below here, but most of these are decision aids. So it's basically helping patients decide whether to have surgery, whether to have a partial or radical nephrectomy. And unfortunately, one of the very first lines in a lot of these guides is this guide might not be for you if you have X, Y, and Z. And I think that it makes sense to do because for some patients, a decision aid is not really appropriate. For example, if you had a larger mass that was really complicated and there was no way for your surgeon to do a partial nephrectomy, well, it's not really helpful for you to read the decision aid between having a partial or a radical nephrectomy because you probably need a radical nephrectomy. But we want to make sure that if we are putting, for example, an educational resource out there for patients with nephrectomy, that it's kind of that we have one that's all encompassing, right? So I think that was kind of important. There's also one here that isn't a decision aid, but it doesn't really talk about the specifics of surgery, right? And the risks and benefits. And some of the feedback that I've heard at least is that patients want to kind of know, some of the specifics about what they're getting themselves into, right? They don't kind of want a blanket statement of, talk to your surgeon if you're concerned about the risks of surgery. And this part of this comes from personal experience. So, my in 2022, as Christine mentioned, my girlfriend at the time and now my wife was have a renal mass, and she was referred to a urologist, and they had many discussions about what the plan was. Unfortunately, her mass was quite large, and so she needed a radical nephrectomy. Now, as her and her parents were having the procedure explained to them, I didn't go to these appointments, but so they would have them explained, and then they'd come back and talk to me. And obviously, as a budding kind of medical professional, I was a bit interested in what the surgeon had to say and what the plan was. And they explained to me that apparently the surgeon was going to cut around the kidney and cut all the mass away and leave the kidney. And I thought that sounded a bit strange, but I kind of went with it because who am I to kind of challenge what their surgeon is telling them? And whether it's that the surgeon actually kind of misexplained it or that they're misremembering, we still don't really know to this day. But I just remember that when she was actually about to go in for the procedure the day of, that was when she found out that she was losing a kidney. And so this is kind of a really big motivating factor for creating this resource, because again, you have a patient who these decision guides or decision aids don't really apply to, who doesn't really know a lot about the procedure that they're getting, to the point where they think they're having a totally different procedure than the one they are, at the time of going into the OR, which was really frightening for her and for her parents, as they're kind of sending her off to sleep. That's definitely the last time that you want to be learning about what your procedure actually entails. So, based on that, I partnered with one of the surgeons at SAU the Southern Alberta Institute of Urology, and we sat down and tried to kind of create a guide, and we quickly realized that we needed a lot of patient feedback. We couldn't just kind of, as two medical professionals, sit down and put together this guide, and so that's when we approached Christine and Kidney Cancer Canada and got some amazing feedback on how we could make this resource quite a bit better and quite a bit more accessible to patients. So I'll quickly go through the resource in terms of what's covered, and obviously at the end, if you have any questions or concerns, please let me know. And definitely this is kind of an ever adapting and changing thing, and I'm as I've kind of chatted with Christine about already, this is something that will kind of hopefully update year to year as both as the medical side of things change and as we get more feedback from patients. So in terms of the initial parts of the resource, it kind of covers the function and the location of the kidneys. And I think that this is really important because it helps build that understanding of some of the complications that can arise. So I think that when patients hear that, that their bowels can potentially be injured in surgery, or their spleen or their liver, it can be a bit confusing if you don't understand the anatomy, that the kidneys are actually behind all of these structures. And so to get to the kidneys, you actually have to move these structures out of the way. And that's where that risk of injuring them comes from. Additionally, I think it's again important to understand function, because you understand that the kidneys essentially balance the body's water, and so if you have too much water, I mean, I'm sure most people know someone who potentially has heart disease and has edema in their legs, and so that can kind of start to happen if we don't have good water balance, and that's not great for your heart. And so starts to build that importance of why we want to try to track our kidney function, and why we want to try and maintain it as much as possible when doing these procedures. And don't get me wrong, most individuals who have a nephrectomy generally have fairly good kidney function after, even if they have a radical nephrectomy. But just important to kind of highlight and understand. Um, then it's also kind of goes into discussing the different types of masses. So some patients are diagnosed with cystic masses, so they're kind of fluid filled, and it can be a bit challenging to understand when or why some cysts are benign looking versus potentially need surgery. And so there's actually a table here that kind of highlights the scoring that the radiologists use. So it's called the Bosniak score, and it essentially gives you the risk of malignancy based on the score, and that can kind of help understand why one cyst is left and one cyst might be removed surgically. And then also talks about solid masses and how it's generally safer to assume that a solid mass is cancer until it's biopsied or removed, and talks about that a little bit. And even though there are benign masses that can be solid, it's generally they're kind of treated as malignant until proven otherwise, especially if they reach a certain size. Also talks a little bit about some of the risk factors for malignancy. So, I think one of the common questions is why, or what led to me developing kidney cancer. And so this talks about some of the risk factors, although it highlights that, in many cases, it's impossible to know whether these risk factors actually led to malignancy. So I think that that's an important piece to highlight, but also to give some idea of what some of the risk factors are, like smoking and high blood pressure and genetic causes. And then also discusses some of the different treatment options. So again, not just nephrectomy, but there's options like the ablative therapy that I talked about earlier, as well as talking about using surveillance in those smaller masses, as well as some of the systemic therapies that are available if someone is not choosing to pursue surgery, but is instead just receiving kind of systemic therapies to prolong life. And then it talks about partial nephrectomy. So kind of some of the basics of the procedure. You can see the graphic there where part of the kidney is removed, part of the healthy tissue is removed along with the mass to create a margin. And then the kidney is kind of sewn back together and is then allowed to kind of to heal itself. But it also discusses some of the surgical risks that are specific to partial nephrectomy. So one that is often either not described by physicians or not remembered by patients is that you can actually get a urine leak into the abdomen after a partial nephrectomy, which is a very low risk of occurring, but it's definitely something that can result in a few extra days in the hospital and can be pretty distressing for patients. And I've seen this kind of play out a few times where patients indicate that this was maybe not described to them, or that they didn't remember it being described, at least as a potential risk of having a partial nephrectomy. And then it kind of talks about, where the incisions might be for a partial, as well as kind of talking about some of the reasons to have a partial nephrectomy over a radical nephrectomy. And then next, a radical nephrectomy is described. And so again, you can see a graphic of what exactly is happening, where the entire kidney is removed, the artery and vein are clamped and then tied, as is the ureter, and then the entire mass is along with the kidney is removed. And it talks a little bit about why your surgeon might favor a radical nephrectomy. For example, if the mass is kind of in the hilum there, or the area of the kidney where the vein and artery and ureter are, it's really hard to try to remove the mass from and just cut out the mass without damaging the artery and the vein. And so sometimes just from up front, it's a better idea to do a radical nephrectomy, because then there's less risk of bleeding to the patient, because you know exactly what you're doing from the outset. And then talks about some of the downsides in terms of kidney function, which I've highlighted at some of the other slides. This goes over kind of general risks for both procedures. So, kind of need for a transfusion, infection, injury to the other abdominal organs, these types of risks, and talks about the occurrence of them in procedures, as well as how this would occur. So, kind of helps to give some understanding as to why this actually might happen to you during the surgery. The resource goes into discussing kind of the expectations after surgery. So again, that piece where I feel like I've talked to a lot of patients where they say, "Yeah, I had the surgery, but then I didn't really have any follow-up plan for my team." And so, this kind of talks about what that might look like, including the hospital stay. So the fact that you're going to very likely wake up with a catheter, and this is something that can be distressing to patients. The fact that you're going to be staying in hospital for 1 to 3 days with a less invasive procedure, or 2 to 5 days if you have an open procedure, and that there's going to be quite a bit of time before you're returning to full activity, up to 6 weeks. It also talks a little bit about kidney function. So there is a story I heard about a patient where they went into the emergency room after they had this procedure, a radical nephrectomy, and the emergency doc told them that they had a kidney injury. And so when our kidney function decreases, that's the term that is used medically as a kidney injury. But the patient obviously thought that that was referring to the kidney they had left. And so they were quite worried about that. And so just kind of explain some of the language and terminology that might be used. And then also talks about some of the follow-up care in case this mass is malignant. And so this slide in particular or this page in the resource in particular goes into what some of the treatment recommendations or imaging recommendations might be, depending on the stage of your malignancy. And so this can help kind of guide, okay, when should I expect to need, a CT scan, or when should I expect to go back and see my urologist? Because all of the intervals and frequencies are listed here. And I think this table can be a little bit overwhelming for some patients. And so certainly, some parts of the resource can be taken or left, but I think that there are definitely a group of patients that really want to know this type of information, kind of from the outset, and want to kind of plan ahead and have some idea of what their care is going to look like. And so that's why we included it in here. And then lastly, just kind of cover staging very briefly. I think staging of any cancer is quite complex. And so we try to stay away from getting into the nitty gritty of it. I think even at like my level of training as a med student, I am still not super familiar with how to stage different types of cancer. So it can be very, very complex, but this kind of gives an overview of about how things are staged, and what a stage 3 versus a stage 4 might look like. And then just some resources. And so this is largely from my personal experience in terms of trying to find resources to help understand the care process for my wife and for her family. And these are it includes also like kind of what information I found helpful at each resource, and again has been kind of vetted by other patient advocates from Kidney Cancer Canada. So that's been very helpful in terms of making sure that they're in agreement with what's been listed here. And then the associated study. So yeah, in addition to developing the resource, we want to do a study to determine that it's efficacious or beneficial for patients. And I think that this is important for a few reasons. One of those is to motivate urologists to actually use it. I think it's notoriously hard to get surgeons to kind of go out of their way and do things that are taking up extra time because they're already so busy. But if we can show, unequivocally that this is beneficial for patients or that patients are really valuing this, then I think that'll definitely increase the motivation to use it. Additionally, to increase patient awareness. So, even if we're not able to get urologists to uptake it as well, if we can show that it has a benefit and can kind of push through the kidney cancer website that it's there and that it has a benefit, then hopefully that'll increase patient awareness surrounding resources like this and they can access them on their own. And then additionally, to create precedents for future resource, there is surprisingly little in terms of educational resources or patient guides in the research realm, at least for kidney cancer. I was actually quite surprised when doing the groundwork for this study, and I think that in order to generate research in a field, there needs to be a base there, and so I think that this will go a long way to establishing that base. In terms of the study itself, we kind of developed the study with a few other urologists at the Southern Alberta Institute of Urology. And then, of course, designed the resource itself along with Kidney Cancer Canada. We developed a protocol to submit to ethics and developed some surveys to make sure that we're collecting feedback, and then got ethics approval and have since begun recruiting patients as well as trying to recruit urologists, which has been quite tricky so far. And then, overall, we'll assess the efficacy of the resource with questionnaires that are given in patients, and then different questionnaires that are given in urologists to make sure that both kind of sides of the aisle are finding this to be a valuable tool. So, in terms of study progress, we started patient recruitment last month, and urologist recruitment we still haven't quite started just because we were kind of trying to do a trial in Dr. Gatto's patients first and then kind of start to roll it out to other urologists. So far, we've recruited around 15 patients who have all completed the survey and have had around 20 additional patients who have expressed some interest but just haven't completed the survey yet. And then in terms of urologists, we only have Dr. Gatto, but plan to kind of recruit others and then also use these other urologists as a method of recruiting more patients to try to get to that goal of 150. All right. And so, I'd just like to acknowledge Kidney Cancer Canada for funding this project, as well as connecting us with patient advocates and making sure that the patient voice is represented within this project. And I'd like to thank Dr. Gatto, who unfortunately wasn't able to be here today, but is definitely a big supporter of this project, has been very, very instrumental in getting it moving. And then thank you to all the patients and their support people who participated and volunteered their time, and especially at a time when they're experiencing very likely quite a bit of stress. And it's definitely very, very helpful to have that feedback and to hopefully make things better for the next person who's diagnosed. So my references, and we'll now take any questions.
Well, just before we take a couple of questions, Caden, I just want to thank you again for your initiative and for reaching out to us. I have to say this was all Caden. He was the author and he took the initiative to create this excellent document. As soon as we reviewed internally, we passed it on to our patient support committee, and they all reviewed it very carefully. We went back and forth on a couple of things, but mostly it was already really well written. We just changed a little bit of the wordage to make sure that it was patient-friendly language. And we are really pleased to be able to support this research and the ongoing this educational tool and this research that will be ongoing. So we'll be excited to hear what you learn, Caden. And I hope that you'll definitely be sharing that with us. We've already had a comment from Linda, and she's thought it was an exceptional resource and wondered where they'll be able to get it. This will live on, we wanted to present this, we wanted Caden to be able to present his resource. So we have already created a print-ready booklet. It is at the printers as we speak. So patients who want a written copy they can email us at info@kidneycancercanada.ca and request that resource. And we certainly send out all our educational resources that you request. We send them out for free. So if this is something that you'd like to have, please send us an email and we'll be sure with the details of mailing, and we'll be sure to send it out as soon as we get it back from the printers. And for our French participants and patients and caregivers, it is in the process of being translated. That takes a little bit of time because we do it medically accredited. So it takes a little bit longer than just having it translated. And on that point, I want to reassure everyone that the information in this booklet has been medically reviewed. So what we are providing, as in all of our publications, is medically reviewed information so that we know what we're passing on to you is correct information. So if you have any other questions for Caden, please write them into the chat or the Q&A, and we'll certainly ask them. But Caden, I have a question or two for you. One, I wanted to say thank you for talking about the health partners, like the taking your family member. Although I'll say, if you take your family member, make sure it's a family member that isn't going to lose it more than you. Because that was my case when I went for my, initial diagnosis appointment. I took my sister, who was going to be my health partner, and, as soon as they said, well, good news is you have a very small tumor, bad news, it's kidney cancer. Well, she just kind of lost it, and then neither one of us retained any information. So we sometimes recommend, and you can maybe comment on this because you work in the urology clinic, we sometimes recommend that if the doctor gives permission to record the session. Do you ever have patients ask that in the urology clinic?
Yeah, I would say quite often. I've done a bit of oncology as well, and I would say it's a lot more common there because I think people are kind of further along in the journey
Mm-hmm.
that point, and they're a little bit more they know at that point that they're not going to retain some of the information, and so I actually think it's probably something that patients should do more often in a urology setting at that
Mm-hmm.
surgery appointment, but is unfortunately, I think, because it's just like an overwhelming appointment and you don't know what you're going to hear, so sometimes can be a little bit lost.
A little bit lost, is putting it mildly. I'll have to say, and this is a common theme with all the patients that we work with and in coffee chat, and you're sitting in the appointment, you hear that word, and everything goes out of your head. You have no idea what anybody's saying after that. And that's when you go home and you hit Dr. Google, and usually that's taking you down. I mean, you've just been diagnosed with kidney cancer. You have no idea what stage, grade, you look at all the information and it's obviously a nightmare. And you don't even need to go that far. Like, you just deal with your surgery. Then you deal with what comes next, if anything comes next. That's kind of the question. And I'm glad that you mentioned paper educational guides, because we do have a lot of patients. Kidney cancer used to be known as an old person's disease. I'm sure you're familiar with that. And obviously that is not very true, as you're familiar with that. We're finding more and more young people, like very early. I'm not sure how old your wife was when she was diagnosed, but I was just speaking with a patient the other day, a young lady, 21 years old. And that used to be unheard of. And we're trying to figure out why. What are the factors? Are you seeing that in your practice a little bit, or?
I would say like 21, 22 is still quite young, like 20s, but definitely 30s.
Yes.
And that's kind of been echoed by a lot of the urologists I've talked to. But yeah, it's not unheard of in their 20s, which you're right. It used to be like pretty much unheard of unless you had like a genetic syndrome that was kind of predisposing. But yeah.
I'm glad you brought up genetics, because if you are a patient, a kidney cancer patient that has been diagnosed, and you're under 50, in fact, under 45, it is very important that you speak with your urologist and or your oncologist about genetic testing, because that could be a big factor, and it is covered, I believe, right, Caden? And you do need to investigate that. It's very important. I had another question about, is the resource going to be online? Yes, same kind of answer. We wanted Caden to be able to present his material first. So it will this week be live on the Kidney Cancer Canada website. We'll kind of put a special banner so that you'll be able to link right to it rather than having to search through the website. So that will be taken care of this week. Unfortunately, as mentioned, the French will not be there quite yet, but as soon as it's finished, it will live on the website as well. It's important that we do everything in French that we do in English. So unfortunately, it just takes a little bit more time. I really liked too, Caden, that, and I'll just remind anybody, oh, I got another question. Nope, same one, sorry. If you did the follow-up chart, and that's really important that patients have that resource to follow, because I have to say that not all provinces or not all urologists in certain provinces follow the CUA guidelines. And it is important to have those checkups. As we've seen here today, like we have patients that, 20 years later have recurrence. So it's really important to at least have some sort of follow-up. Maybe it's every 1 year, every 2 years with your family doctor. But once you're kind of released by your urologist, please make sure you continue to be followed. It's really, really important. I had another question, 2 questions pop up. Hold on one second. Caden, where did you say they could get the Bosniak score?
Put a table in the resource. That one would have also come off of the CUA website or CUA
Yeah.
guidelines. So in terms of the percentages that are there, yeah.
Okay.
Yeah. So
Okay.
I think the CUA website, so that's the Canadian Urologic Association
Mm-hmm.
website, is a little bit jargony, a little bit tricky to navigate just because it is made more so for healthcare providers. But definitely, if you take a look at the resource, then that the table and the summary of the findings is there.
Okay. So if we had a patient that was identified to have, a Bosniak cyst, and they were looking to find out what score they were, that would be in their pathology report, or would they have to contact the urologist?
That would actually, so that would come, they should contact the urologist, but it would come from their radiologist. So the Bosniak score is a radiology, as a score that's assigned by radiology. So they
Mm-hmm.
basically will look at the cyst in imaging. And the reason that it's not a pathologist is that when you have a cyst, it's fluid filled. And if
Right.
you biopsy it, that leaks everywhere. And who knows if there is
Right.
malignancy in there, then that's, you've just kind of spread it or seeded it.
Yes.
So yeah, so that it comes from the radiologist, but yeah, your urologist would be able to tell you because that's kind of how they'll decide is that, you'll get your ultrasound, you'll get your CT, and then based on the Bosniak score that the radiologist assigns, they'll dictate whether they think it's appropriate to move forward with surgery or clinic.
Okay, so next steps would come from that. So basically, not everybody has access, but I know many of our patients, especially if they're going to a regional cancer center or one of the major cancer centers, you can tap into like something like My Chart. I'm not sure what it's called in Alberta. Caden is based in Alberta, but you will get your radiology report from your My Chart or whatever, and it should state in there. But anybody who's questioning, just contact your urologist's office and ask that question, and I'm sure they'll be able to help you out and better guide you to next steps. speaking of Bosniak cysts, I was speaking with a specialist just this past week in regard to maybe we'll do a short webinar on Bosniak cysts, because I think there's a lack, as you found, there's a lack of information. So that might be beneficial. And then we could also maybe have a short resource, that's available to patients from that isolated diagnosis. So keep in mind, please watch for that coming forward, probably in 2026. We will be looking forward to doing something on the Bosniak cysts. So Caden, thank you so much. I'll just remind everybody that Caden will update us on his research going forward. We are so grateful to him for creating this excellent resource for our patient community. And it will go live on our website this week. So you will be able to tune in and read the resource. And it is actually going to print. So if you'd prefer to have a printed copy, then that will be available coming soon, as soon as we get it back from the printer. So thank you so much, Caden. Congratulations.
Thank you so much for
on
having
this.
me.
We're expecting great things from you now. You know that, right?
Yeah, pressure's on.
Okay. Thanks
All
again.
right.
Take
Thanks for
care.
having me today. Bye-bye.
Bye-bye. I hope that you got some great information from that session. I know I did. I learned a couple of things. I always learn something at these sessions, and I also always learn something in coffee chat. Somebody brings something forward, and we have a bit of a discussion. We're not medically trained there, but it's always good to have a discussion, and then we can take that information back to our medical professionals